Polycythemia vera is one of the classic chronic myeloproliferative neoplasms that is associated in almost 100% of cases with mutations in the JAK2 gene that results in an overactivation of the JAK-STAT signaling pathway within hematopoietic stem cells and their progeny. So a hallmark of polycythemia vera is an increased hematocrit level. The hematocrit is the proportion of whole blood that is occupied by red blood cells. In other words, polycythemia vera is characterized by an expansion of the mass of circulating erythrocytes. And it has been shown in a recent phase 3 study that has been published in the New England Journal of Medicine at the end of last year that the control of hematocrit is a key therapeutic goal in the management of patients with polycythemia vera, since patients maintain it at less than 45% hematocrit, that is close and even lower than the normal range, for example, for male, present a significant decrease in the risk of cardiovascular deaths and major thrombotic events. The way we can control hematocrit in these patients may be represented by phlebotomies, removal of blood volumes, and in high-risk patients for thrombotic events, we need to use cytotoxic drugs, and the most commonly used drug is represented by hydroxyurea. Unfortunately, about 20 to 25% of the patients may develop over time resistance or refractoriness to hydroxyurea. And so these patients really represent an unmet therapeutic needs in these disorders. We know that ruxolitinib, that is a JAK1 and JAK2 inhibitor, and therefore targets the abnormally activated JAK-STAT signaling in these cells, has the potential to control hematocrit and also to reduce the spleen volume and to improve symptomatic involvement in patients with polycythemia vera, as recently shown in a phase 2 trial. Therefore, the phase 3 trial that is called RESPONSE trial, that will be presented tomorrow in the late-breaking abstract session, is a phase 3 prospective randomized trial where ruxolitinib was compared to best available therapy with the objective of maintaining hematocrit control and also reducing the spleen volume in patients with polycythemia vera. Best available therapy was at the investigator choice and could be one of the most commonly used agents in the treatment of these patients. So the primary response was measured in the RESPONSE study at week 32, and this was a primary composite endpoint that was represented by the proportion of patients who obtain the control of hematocrit in the absence of phlebotomies, as well as a target reduction in the spleen volume of at least 35% compared to baseline by MRI. And as you can see here, the proportion of patients who obtained the primary composite endpoint was 21% in the ruxolitinib arm as compared to only 1% in the best available therapy arm, and the difference is, of course, highly significant. Furthermore, 77% of the patients who were randomized to ruxolitinib were able to meet at least one of the two components of the primary endpoint, and in particular, 60% of the patients in the ruxolitinib arm, as compared to 20% in the best available therapy group, were able to obtain the target control, less than 45% of hematocrit, without phlebotomies, and 38% of the patients in the ruxolitinib arm, as compared to 1% in the best available therapy group, were able to obtain the target reduction in the spleen volume. Furthermore, the treatment was highly effective in improving the symptoms that are associated with polycythemia vera, and these were measured by patient-reported outcome, specifically this MPN-SAF symptom score that has been developed over the last years and validated specifically for patients with myeloproliferative neoplasms. And as you can appreciate here, 49% of the patients randomized to ruxolitinib obtain an at least 50% improvement in the symptomatic score as compared to only 5% of the patients in the best available therapy group. And this improvement could be seen in the three main domains where symptoms are clustered in these patients: those that are related to the abnormal release of cytokines, particularly itching and night sweats, those that can be ascribed to the increased red cell mass circulating in the blood, and also those that are related to the enlarged spleen, particularly early satiety and abdominal discomfort. Treatment with ruxolitinib was well tolerated, and indeed when adjusted for exposure in terms of 100 patient years, the rate of adverse events and also of those of grade 3 adverse event was half in the ruxolitinib arm as compared to the best available therapy group. And there was no additional, no novel toxicity that was recorded in this study as compared to the information that we have from the pivotal phase 3 Comfort 1 and Comfort 2 studies that led to the approval of ruxolitinib for the treatment of patients with myelofibrosis. And in particular, the most recurrent toxicities of ruxolitinib that are on target effect of the drug on hematopoiesis, particularly anemia and thrombocytopenia, occurred at very low frequencies in patients with polycythemia vera. Therefore, in conclusion, results of the response study indicate that ruxolitinib was superior to best available therapy in controlling the hematocrit without phlebotomy and in reducing the spleen volume in patients with polycythemia vera who were resistant to or refractory of hydroxyurea. Ruxolitinib was also very effective in improving the symptoms that are associated with polycythemia vera, and the treatment was well tolerated, as supported also by the fact that 85% of the patients in the ruxolitinib arm were still on treatment at a median follow-up of 81 weeks, and that 86% of the patients cross over from best available therapy arm to ruxolitinib because of lack of efficacy at or after week 32. In addition, a very exciting finding from this study was the observation that patients in the ruxolitinib arm experienced significantly lower thrombotic event. There was actually only one thrombotic event in the ruxolitinib arm as compared to 6 events in the BAT arm, in the best available therapy group. Therefore, overall, this data suggests that ruxolitinib might represent a new treatment option for this specific category of patients with polycythemia vera who have an unmet therapeutic need with the current use medications. Thank you.
Thank you very much. Any questions to this presentation? Yes, please.
As I understand, hydroxyurea is one of best available therapy. But these patients were resistant or intolerant to hydroxyurea. Don't you have to compare with those who can tolerate hydroxyurea? Because when you exclude the most common best available therapy, you have worse best available therapy. I think, isn't it something wrong with this study when you can't compare with hydroxyurea? It was the same if ruxolitinib, they who can tolerate that. I mean,
I think you are raising a very good point. Your question actually points to the use of ruxolitinib as first-line therapy, if I understand correctly your question. So I think that as in any type of new drugs usage, we usually start from patients who actually have severe problems with the current therapies. So patients who are doing well with hydroxyurea are still maintained on the drug because there are data that indicate that hydroxyurea is definitely better than phlebotomies only in preventing thrombotic events. That are one of the major complaints of these patients and also one of the major causes of death in these patients. So I think this is the first point. We usually start from the categories of patients that actually need improvement in their therapeutic approach. The second point is that we really are in shortage of effective drugs for this category of patients. Most of these have an advanced phase of polycythemia vera. An alternative might be interferon, but this trial, after all, represents what is the current way of managing these patients. So we have patients with polycythemia vera who are clearly refractory or resistant or have intolerance to the drug, but we may continue to treat them with hydroxyurea because we have no alternative. That is not the case for patients who are doing, after all, quite well with hydroxyurea. So the aim of this trial was really to focus on a narrow category of patients for which no definite alternative right now exists. Of course, the fact that ruxolitinib in this difficult category of patients showed an efficacy also on the reduction of thrombotic events leads us by hand to your point and led us asking whether this drug might also find a room for first-line treatment.